Alright, I'm Ricardo. A lot of you know me. I do charge relief during the day, and I'm a nurse on day shift here on 6 West. I have to do a presentation for school, so it's going to be on external ventricular drain, setup and management. So to start off, we'll just begin with the Monroe-Kelly doctrine. Does anybody know what that is? No. Alright, so the Monroe-Kelly doctrine states that your head is a closed system because your skull, so there's nowhere for anything to really move. And then our heads are made up of 3 substances: CSF, blood, and brain. The brain takes up 80% of the room, blood is 10%, and CSF is another 10%. So in a closed system, if you increase the volume of one of the substances, then you're going to end up squishing the other 2 substances. So, for instance, I'll show you in the next slide. The picture here, your normal brain is right here. Your CSF is even, brain, and blood. If you end up with edema in the brain from, say, like a TBI or anything like that, your brain edema is raised, so you're going to be pushing off your blood and pushing off CSF into the closed system because there's nowhere else for it to move. And then in hydrocephalus or increased ICPs, you're going to increase your CSF, which then pushes everything else out. And if it has nowhere to go, it'll go down the brainstem and you'll end up herniating. So CSF and ICP. CSF is about 150 mLs traveling through your body at any given time. And it produces 600 mLs daily. And an ICP, a normal ICP is between 5 to 15. When we have kiddos with the EVD in and everything like that, usually they let you stay below 20 millimeters per mercury. So some reasons why we would end up having an EVD. Cerebral edema, such as an intracranial hemorrhage, intraventricular hemorrhage, subarachnoid hemorrhage, cerebral venous thrombosis, or ischemic stroke, hydrocephalus, and any surgery complications. So if they're going in to remove a tumor and ends up having, you end up having increased ICPs, your space is going to expand and you're not going to have anywhere else to go. So another way to manage that also is they'll do a craniotomy, partial craniotomy, and take out part of the bone to help the brain be able to expand. And then we have our EVD. So to set it up, we go and get our pole from the equipment room, and we get our mounting bar, which is here. It's usually, if we end up putting an EVD in at bedside, it's going to be on the neuro part as well, so it's easy spot to grab it, but there's also different ones, separate ones inside the utility room, the clean utility room. And then we just place it on the pole and screw it in and make sure that it is tight. So now we have attaching the clip to the drainage system and the stop cock to the mounting bar. So your EVD will come set up already from OR pretty much like this. And it'll already be attached to the patient. So when it says to attach the clip, this one already has the clip attached, so I don't think it'll let me, I got this. So it's really important to make sure you attach the clip correctly. Follow the arrow that says up and put it up through this way, because if you put it this way, you're not going, it's not, 1, going to go in, and 2, it won't sit on your mounting bar correctly. So just push it up, and then you'll take this, place it right here, and then attach your stop cock to this part here. Alright. So then we're going to also then inspect all tubing to make sure there's no kinks, there's no debris, there's nothing inside the tubing itself. Now, if you end up having to set it up at bedside, you are going to have to prime the tubing down and also prime the tubing into the Ventricular right here. So to do that, you will get sterile gloves, mask, gown, alcohol swabs. You'll want to use alcohol swabs because the chlorhexidine gets sticky to the plastic, and it will be really hard to get the syringe back off, sterile saline syringe back off, and also your ICP monitor. If you have to put that on, it'll be hard to screw that on as well. So priming wise, you want to prime with no preservatives, sterile water. You grab a sterile syringe of normal saline and have that at bedside. Since it's all sterile, make sure you grab a sterile one, but for presentation I'll just use a regular syringe. So you'll want to clean, don sterile gloves, clean, and there's usually a red cap right here that you'll end up taking off. And you want to do it with someone else, so you have another RN with you. So the other RN can take the red cap off for you while you're sterile and everything like that. So then we'll clean this part here. Make sure that it's also off to the drainage system. Since there's nothing in it and it's not connected to the patient, it's okay to be open, essentially open right here. So then we'll do that. Sterile, the sterile nurse will come put the saline on, syringe on, screw it on. Now we'll have to turn it off to the patient to prime up through the Ventricular. So we'll go slowly until we can see the meniscus traveling over, up through, and then up until one drop goes. And then we'll do the same thing the other way. So flip it all the way up, off to the Ventricular and open to the patient, and then follow it all the way down as well until you get a drop out here. Make sure all your stop cocks are open. There we go. And then you can turn it right back off like that, and then you're primed. So then when the neurosurgeon says that they are ready for the tubing to be attached to the EVD, then you hand it to them to attach it, because nursing wise we're not allowed to actually physically attach it to the EVD, which is what that says. Alright, then we want to check our orders and make sure in SCM that all of our orders are correct. So you want the start date, and then you want to know where your drip chamber is supposed to be at in meters of water. So this side here is going to be meters of water. If they say they want it at 10, you want to bring it up and line up this yellow line right here to 10, and then lock it in place. And then your 0 point is always going to be the external auditory meatus, or the tragus. So you'll want to turn on your laser, which you have there, you can't really see. Put it up to the tragus of the ear of the patient. Use the bubble on your leveler and make sure that it's even in the middle. And then at that point, as long as your patient's not going to move and you're set, then you can go ahead and open the drain to the patient so it's able to begin draining. So which way do you want to position the stopcock pointing after you open, after you zero everything out and it's where it's supposed to be and the patient's not going to move? Which way does the stopcock go? Does it go up, sideways, or down? Level. Perfect. And then if you are going to clamp it towards the patient, which way does that go? Down. Perfect. And why do we want to clamp it when we are either positioning a patient or manipulating the clamp or anything like that? Why do you want to clamp the EVD?
Don't want it to drain too fast.
Don't want it to drain too fast, exactly. Perfect. All right, and I just explained leveling. And if the batteries ever die on the leveler, the PCT cart actually has the small batteries for this on the east side. They're in a little cart that they can grab for you. All right, so we have to do hourly checks. Usually we have Q1 hour neuro checks on our patients with EVDs so that we can also document how much CSF has drained from the EVD. When we do that, we want to make sure how much volume has drained out, chart that, and also what the CSF fluid looks like in the bag down here. If it's clear, then it's normal. Yellowish, it could indicate some infection, and pink or red, it'll be a recent, or if it was recently placed, it'll be pink or red because due to the trauma and everything like that. 10 to 20 mLs an hour of CSF drainage is pretty normal. If you end up in a 1 hour period where you end up having like a 30 or 40 cc increase in your CSF, you'll want to let the team know and the neurosurgeons, as well as if there are any changes in ICP. So yeah, let the team know. So drainage of CSF bag is this yellow stopcock right here. So every hour you'll go in, document how much is out, and then you'll turn the stopcock to the left or right, make sure it's parallel, and then sometimes if the bag is brand new, you can just squeeze the bag like this a little bit and open it up, and it'll create a vacuum, and it'll vacuum out the CSF from the urethral. Most important things to remember is to either put it back down again or back up, because if you forget and open up your drain, every time it drips, it's just going straight into the bag, and you're going to miss that hour's worth of CSF. And then remember to open up your drain when you're leaving the room. Troubleshooting wise, so if you have no drainage for an hour, the first thing you want to do is look at your patient. Make sure that they don't have any signs of increased ICP, such as dilated pupils, nausea, vomiting, headache, irritability. They're not any different. Late signs of ICP could be Cushing's triad, where you'll have hypertension, bradycardia, and irregular respirations. Next, you'll want to go and start at the head of the patient. So check the patient, then start at the head. Check the insertion site, make sure the EVD is in, make sure it's secure, there's nothing leaking or anything like that. From there, you'll want to check your tubing, and you want to check your tubing for debris, clots, cracks, kinks, and make sure all stopcocks are open. Usually, if your patient is coming from the OR and this is already connected, they'll have this one clamped. So then when you go to try and find your ICP or see if it's draining, you won't be able to because it's clamped all the way up here. And a lot of people tend to forget that it's clamped up here. So make sure that that is open, which is going up, and then your CSF will begin to drain. And also, again, make sure the bag is closed. And then, if everything is normal, there's no kinks, there's no cracks, everything is fine, you'll want to take your urethral and drop it down. If you do that, the meniscus in the top will rise and move, and then that'll tell you that it's actually patent. If it does not move when you drop it, even if you take it off of here and drop it even lower, if it doesn't move and you don't see a bounce, then it's probably clogged and your tubing is just fine, and it's probably clogged inside, and the team will need to know so they can go in and fix that. Now we'll talk about hooking up the ICP or drainage bag. So when to change the drainage bag? It's 3/4 full. It's a semi-sterile procedure. You always want somebody else with you. Always use the alcohol swab as well so that the bag doesn't get stuck for the next person when they have to change it. You'll don sterile gloves. Someone will take it off for you, and then you put the new one back on after you clean it. And you want to do that when it's like 3/4 full. So usually when it's about 350 to 400. So adding ICP monitoring, you want to gather your supplies. The ICP monitor looks like this. It's in our supply room. Remember, it does not have a pigtail on it, so if you grab the one with the pigtail, it's actually for your art line or your CVP. It's also chargeable, so make sure you charge it out on the computer inside of the supply room. You want mask, gloves, and alcohol. So to prime the transducer, I already have one out here for you. You'll want to take off all extra tubing. So we don't need any of this here. They probably use Clorox too. There we go. And then you'll attach your saline just like it was here. This red cap you can take off, attach your saline to here. It's also there we go. Attach the saline. You'll want to prime this as well. Then you'll clean this like we did the last time with alcohol. Bring this in, attach this to here, and just rotate it on. And then make sure it's clamped down to the patient. And then, there we go. Then you will attach your cable to your monitor. Red, either you could do it on the top here, or they'll have an extra box for you to do it. And then you can attach it to your ICP monitor, like that. When you go to zero out for your ICP, you want to make sure the yellow line is at the 0 mark. You'll, on the monitor, go ahead and hit 0 ICP. When you hear 2 beeps, you'll then raise the Buretrol up to your ordered height per water, so 10. And then you go ahead and level it as normal like you would, and make sure you'll get your ICP once you turn it off to the Buretrol itself, which is up. Turn it up, you'll get a waveform, and you'll get your ICP. That's what you'll do every hour to record your ICP. So we do one-to-one replacement as well. So children in PICU are super susceptible and at risk for SIADH and cerebral salt wasting. So follow sodiums closely. Usually we'll do Q4 hours and then push it up to Q6 hours and then maybe Q12 after that. The one-to-one replacement is to help, is normal saline. If you have, what we do is we replace it every 4 hours. So if you have 40 mLs out of CSF in a 4-hour period, you would divide that by the 4 hours and you would have a replacement going in at 10 mLs every hour of normal saline. And they'll trend the sodiums. And there's just a bag of normal saline. And that's it. Any questions?